Now, let's look at a scene with a caregiver and a depressed, demented patient.
You ready for lunch, Fred?
Lunch? I just had breakfast.
Breakfast? That was hours ago. All you do is watch that TV. What are you looking at?
I don't know. Something. Some game show.
Which one?
I can't remember.
Well, anyway, it's lunchtime.
I'm not hungry. I'm kind of tired. I think I'll take a little nap.
No, if you take a nap, you won't sleep tonight. You slept late this morning. You can't possibly be tired. Come and eat lunch.
Oh, I don't want to. I'm tired.
What are the ABCs here? The B, behavior, is the patient refusing to eat his lunch. However, part of this is his general disinterest and apathy. With depressed patients, often you see a combination of symptoms which go together. What is the A, antecedent? It is the caregiver announcing lunch. It may seem that nothing really happened to make the patient refuse to eat his lunch, but let's take a closer look. He has been sitting, getting no exercise, in front of the TV all morning. Apparently, no other activities were arranged for him by the caregiver, and he may no longer be able to plan any for himself. Often, patients with dementia and depression behave like this. He is sad, complaining of fatigue, lacking interest, and generally non-responsive. The C, consequence of the patient's depressed behavior and refusal to eat, is that the caregiver tries to prod him to eat. She tries to convince him it is lunchtime and that he should eat, but she is unsuccessful. He just wants to be left alone and go to sleep. Often, trying to motivate such a patient can be very difficult and actually cause the caregiver to start feeling bad themselves. Let's look at another way to handle this situation for more successful results.
Are you ready for lunch, Fred?
Lunch? I just had breakfast.
Well, I guess the morning just flew by, but it's lunchtime now. It's 12:30. That's when we have lunch every day.
Oh, I'm not very hungry. I'm tired. I'll take a little nap.
I'd sure appreciate it if you'd keep me company while I have lunch.
Oh, I'm tired.
Maybe a little change of scene will pep you up. Come with me to the table. I've made cheese sandwiches and tomato soup. I know you like that. Why don't you try a little?
Maybe I will.
When we finish lunch, we'll go to the store and buy some ice cream for later.
Huh? Ice cream?
What were the ABCs here? The B, behavior, was the same as earlier, the man refusing to eat lunch. The A, antecedent, was also the same, the caregiver announcing lunch. But this time, the consequence was different. In this case, the caregiver did not try to convince him it was lunchtime or push him to eat. Rather, she went along with him and didn't dismiss his feelings that he had just had a meal. She agreed that the time had gone by quickly, but also assured him that it was indeed lunchtime now. Rather than push him to eat, she instead asked for his company at lunch and made lunch sound more enjoyable to him. She also did not give him much of an opportunity to refuse. As you can see, the caregiver had more success this time, and so the C, consequent, was that the patient got up to go to lunch. Often, it is hard to tell whether a patient is showing symptoms of depression or if the confusion which accompanies dementia is causing their behavior. To actually diagnose depression in patients, a thorough examination is necessary, since many of the symptoms of depression and dementia can look alike. However, there are things to look for that can help you decide if your patient is depressed and needs help. When patients with dementia are also depressed, their sadness may be expressed directly, or it may be evident in the way they act. For example, they may no longer enjoy activities or interests the way they used to. They may cry often or want to stay in bed all day. In clinical depression, there are a variety of symptoms which accompany the sadness and make day-to-day living more difficult. Here are some symptoms to watch for that will give you a clue that the demented patient is also depressed. The most prominent symptom of depression is pervasive, depressed mood, or a change in the level of interest and pleasure in usual activities. Patients often refuse to do the things they used to enjoy, and sometimes, even when they do them, they no longer enjoy them. There are also other symptoms of depression to be alert to. These include significant weight loss or weight gain, a significant change in appetite, eating a lot more or a lot less, insomnia, not being able to sleep, or hyposomnia, sleeping too much, agitation, restlessness, or psychomotor retardation, being slowed down. For example, if someone is agitated, they may find it hard to sit still, getting up and down often. If they have psychomotor retardation, they may be considerably slower to act, move, or talk. You may notice a lack of concentration ability or ability to think and make decisions. Fatigue or loss of energy is another symptom. Patients with depression often complain of feeling tired and having no energy to do things. They may also express feelings of guilt or worthlessness, fearing that their problems are a punishment for past sins, or saying they are worthless, a burden, of no help or use to anyone. Or they may have recurring thoughts of death or suicide, saying that perhaps they and everyone else would be better off if they were dead. They may even talk about attempting suicide. If this is the case, you should not hesitate to seek help. Sometimes you will be caring for a patient who cannot put their thoughts into words for you, yet you know they are feeling distressed. You may notice a marked change in their mood at certain times of the day, around certain people, or during specific events. Watching the patient's actions and the words they use, or their nonverbal or body language, may point out to you when they are feeling depressed. Even though a patient may not be able to tell you verbally, sometimes they will be feeling or acting depressed. The nonverbal patient will also need your help to overcome depression. Obviously, many symptoms of dementia and depression look similar, and you won't always be able to tell what is causing what. So as a general rule, if you see the sad mood, lack of interest, and a number of the other symptoms described, you should consider that depression may be present. At that time, you may want to consider a professional examination for the patient. What causes depression? We can't always know why depression happens. Depression may be brought about by an upsetting experience or by repeated upsets and sad incidents. A change in the patient's nervous system, which is beyond his or her control, may also cause depression. When a person is depressed, their emotions, behavior, and thinking are all affected at once. This can contribute to what is called a downward spiral or a cycle of depression. For example, a depressed person feels sad and lacks interest or energy. With that comes a decrease in activity. They feel sad and they do less. The less they do, the more isolated they become and the sadder they feel. The sadder they feel, the less they do, and so on. Sometimes depressed patients are in situations that really are awful for them. Patients with depression and dementia are often no longer able to do things they used to enjoy, and this may create a situation that is difficult and unpleasant for them. Depressed people also tend to focus on the negative things that do happen to them. They may think the world is against them and that life has no meaning. Dementia patients may become depressed about events that happened long ago in their past, and they may become overwhelmed by memories of sad events that they remember as if they were just happening now. When a patient with dementia also has depression, that depression can be said to cause excess disability. This means they have more than their share of problems. Not only does the patient have to deal with the problems of dementia, they also have to cope with depression. Your caregiving is also made more difficult by this excess disability. So it becomes important to see if you can improve their depression to improve their lives and yours. What can you do to try to reduce depression in a patient? Emotions, behavior, and thoughts all work together to create and maintain a depression. This chain of events and cycle of inactivity needs to be broken in order for the patient to recover. The best way to do this is to increase their enjoyment of life by providing them with pleasant activities and interactions to help them. By using pleasant events, you may be able to break this downward spiral and improve their mood. Even in patients with some underlying physical cause for depression, increasing pleasant events and decreasing unpleasant events will help. As with other behaviors, you want to focus on the ABCs to figure out how changing the A, antecedent, or C, consequent, can help change the behavior. In addition, there are some general guidelines. Remember, the main thing you can do to improve a patient's depression is to increase their level of pleasant activities and decrease their level of unpleasant activity. This includes social, physical, or solitary activity. Using your knowledge of what the patient used to enjoy, think of some pleasant activities you can schedule daily or a few times per week. Pleasant events needn't take a long time, nor a lot of preparation. They may be as simple as looking at pictures or going for a walk for 5 or 10 minutes. You decide what activities may successfully cheer the patient and how long to do them. Reassurance, encouragement, and enthusiasm are helpful in motivating depressed patients. Introducing new activities gradually or allowing the patient to participate by just being around a pleasant event may help. For example, listening to music or being around a group who is singing may prove to be enjoyable, even if the patient does not directly participate by singing. Chatting about favorite topics or happy events from the patient's past can be pleasant also. You may be able to think of things to talk about or do that you find pleasant as well. That way, you can do things that you can both look forward to. Don't get into an argument about any activity. If the patient does not want to participate, try to break the activity into smaller and more agreeable steps for them. Remember to be enthusiastic yourself. Patients may be unable or unwilling to participate in a pleasant event because of the problems they are having with their memory. The event you have in mind may be too complex. Therefore, instead of being a pleasant event, it could turn into a frustrating and unpleasant event for both of you. The important thing to remember here is to motivate the patient gently, not to push. Simplify activities as much as possible. For example, the patient may have enjoyed card games in the past, but now can no longer follow the game. You may be able to play a simpler game. Go fish instead of bridge. If all games are too difficult, the patient may still enjoy making-believe card games, like sorting through and arranging the cards. When thinking up pleasant events, start small and stay simple. You may find at first the patient refuses to do any activity, but once they have started, they enjoy the activity. This means you've selected the right activity. Change and new activities are sometimes upsetting to the patient at first, but keep trying. Starting with small steps and keeping your schedule as flexible as possible allows you to use opportunities throughout the day for providing pleasant events. Once you've found some suitable activities, you need to schedule them at regular intervals to give them a chance to work. Remember, often dementia patients live in the here and now. A future event or a past event may be too hard to imagine or be forgotten. So as much as possible, and for the best results, you need to provide pleasant, positive activities on a frequent and regular basis. Be flexible so you can make changes to activities or to the schedule as needed, but be sure to offer them. Judge whether or not something is pleasant by the patient's reaction. Keeping the patient active and offering varied opportunities for them to enjoy themselves is worthwhile. In summary, be sure to balance between too much and too little activity and stimulation. And be sure that the patient will enjoy what is planned and that it is within their abilities to participate. To arrange a truly pleasant event for the patient, figure out what is or what was fun for the patient. Be sure it is reasonable and fits their abilities. Divide the activity into small, manageable steps and introduce it slowly with a lot of encouragement. By considering what the patient enjoys and is capable of doing, and by offering new activities, you will help break the cycle of depression and will be on the way to providing a more enjoyable life for your patient and yourself. If increasing pleasant activities on your own does not seem to be helping the patient, you may want to consider professional help. A psychologist can assist you in deciding what to do next, or a physician can consider medications to improve the patient's mood. We've discussed two ways to work with demented patients who are also depressed. These two approaches work best when used together. The first is to identify the ABCs of depressive behaviors such as refusing to eat, crying, or negative statements. The second is to identify pleasant events and incorporate them into the patient's daily routine. By using these strategies, it is often possible to significantly improve the patient's mood. When caring for a depressed, demented patient, you need to be aware of your own energy level and health. You need to take good care of yourself. Caring for a depressed dementia patient is a difficult job, but not impossible. Helping relieve depression may make a significant improvement in the patient's quality of life, one that you can be proud of. In the final tape of this series, we will discuss further how important it is for you, the caregiver, to take care of yourself and give you some suggestions for how to do so. Other tapes in this series introduce other difficult behaviors commonly encountered by caregivers and show how these behaviors can be observed, broken down into ABCs, and changed.